Good afternoon, ladies and gentlemen. A warm welcome to another edition of APAC Dialogue. And we have with us as our guest today Mr. Bhoopendra Solanki, the CIO of Sakra World Hospital. And he will take us through the technology initiatives undertaken at Sakra and the impact and the outcomes achieved as a result. And towards the later part of the interaction, we would like to extrapolate that into, in some way, how technology is improving the patient care delivery in the overall healthcare ecosystem. So before we start, a very brief on APAC News Network. We are a media and knowledge sharing organization headquartered out of Noida with a pan India presence. And we focus on technology deployment in various verticals. Healthcare definitely is one, governance, education, BFSI, manufacturing, startups, and the likes. So, without further ado, what I would like to start with, Bhupendra, maybe if you can just briefly for our viewers inform about your roles and responsibilities at Sakra, and then take us through a sort of an update on all the major or the key technology initiatives that has been undertaken in the last 2 3 years at Sakra. Over to you, Bhupendra.
Yeah, hello everyone and good afternoon. Let me reintroduce Sakra. So Sakra is the first FDI hospital in India with collaboration of Toyota and Sicom. So Sicom just like Fortis, Apollo and other chain in the India, same way Sicom in the Japan. So two major partner this driving this Sakra healthcare in India. And my role in Sakra is like chief information officer, taking care entire IT operation, will closely in line with the business need and patient care outcomes. So that is the biggest role in healthcare, because in healthcare IT is not a revenue generation or direct impact to the revenue. It is a direct impacting the patient life. So it's a life threatening thing. If we are providing information on time, then we can save or we can cure the patient before the time or on right time, we can say, and reduce the mortality and other things as well. So healthcare IT is the important or key responsibility to drive the processes which we run in healthcare, I think 10 years ago or 2 decades ago, manually. Now it's driving through the technology. Coming back to the Sakra, yes, being a Indo-Japanese culture, they love to bring the technology in the any process. Like you can see the assembly line thing in the Toyota manufacturing plant. Same way they want to bring the technology in each process to bring the clinical quality, clinical care quality with the help of technology. Towards this, management always keep a certain buffer budget to bring the those idea which coming during the year, not the previous year. So that helps to bring any new technology wherever it's getting pitched by the doctor, nurse, or any patient is giving the input. Like you can enable these things. Before COVID, even one of the patient given the input, sir, why not you start the report delivery on our email ID and all. Then somewhere 2019 we started, and beginning of 2020 we started that. So that input help a lot during the COVID time. Means we were ready when COVID came with the this report delivery, online registration, means hospital registration they can do from their home, and consultation with payment, without payment, video consultation. So during COVID time, the pressure from the management side, from the patient side, or paramedical clinical staff side, not much came to IT, because we were ahead, we enabled those things in advance. During COVID, somewhere we realize we can think in other areas as well, like X-ray reporting, just kind of a repetitive task of the consultant. Then we engaged one of the partner, and then we brought the ML thing. With the help of, we were doing the reporting of X-ray. So that POC we done, and that was successful. And then main radiologist is checking after the report coming from the system. They are seeing the X-ray film and checking the report. So both are almost matching. Still, because it's a clinical care, our this main radiologist always see those report. But earlier he were taking time like 5 minutes in a report. Now only few seconds is required just to see the report, see the X-ray film and the reporting part. So that way we managed the radiology, and then we reduced the workload, and we were able to serve the more patient during the COVID. Because one of those like RT-PCR, Abbott, few tests are there to identify the are you a COVID patient positive or not. But X-ray also one of the higher level tests where the doctor can identify, okay, this is a COVID patient or it's a not non-COVID patient. Similarly, like abnormal values we called in the healthcare segment, like a certain parameter. This I'll take one example of this sugar content. Sugar 100 means correct, less than 100, if more less, then it's a critical, if it is higher, more higher, then it's a critical. So those algorithms we build in the system, and whenever result getting generated through the system, then if it is lower than critical, if it is more higher than critical, so this same time that alert going to the treating doctor, either it's a inpatient or outpatient, and then along with the patient detail. So doctor no need to go here and there, he can click on that number and call that patient directly and tell, or change the medication and all. So those things we enable with the help of technology. And then being a Japanese culture and the Indian mindset, we brought a technology a level where we can drive other processes as well with the help of technology.
Thank you, thank you. So you explained beautifully the outcome of the processes, and yes, obviously, COVID was one sort of catalyst which drove the technology adoption faster. What I would like to
Really.
understand now, the way you explained the processes and where technology is being used. If we take up specific technology deployment, there are broadly few areas in a hospital. One will be the operations. You explained very beautifully the operations process where technology is being used, the radiology, and then the tests matching and the mapping, and there are different stakeholders.
So
So
network
operations part is one, and the healthcare information system, the software
is
will be. So let's first start with operations. So where all in operations IT has been deployed, and if you can briefly explain the use cases, what sort of technology has been deployed there.
okay. So like in earlier answer I mentioned, this ML technology we utilize for this X-ray auto reporting. Same way we relied on the OPD process, OPD journey of the patient to consult with the doctor. During the COVID, there was a huge this talk, or we can say patients are afraid to exchange the things, either it's a pen, paper, or even exchange the card, credit card and debit card, those things. So what we did, we we automate our OPD process with the help of technology. Like if patient is doing the or taking the appointment online with payment, so they no need to check-in is enabled through in their mobile app, as well as kiosk are there, and they can do the checking through kiosk in the OPD, or through the mobile app check-in, but within a Sakra. Because geofencing is enabled in that, they can't check-in directly into doctor QMS. Means no need to stand for the billing, because their name is reflecting directly into the means no need to stand for the billing, because they already prepaid. So once they do the check-in either through mobile app or through kiosk, that information pass on to HIS, and HIS generate the invoice, and within a minute that invoice getting pushed to their WhatsApp and their mobile app as well as through email. So three mode we enabled for the invoicing, and doctor is seeing that work list where whatever patient are checked in, means they are arrived in the hospital, and billing also done. Either it's through the desk or through automated way. So doctor is calling from the inside, patient name is reflecting like in progress, and they can go inside and consult with the doctor. Doctor utilizing the EMR, feeding the information into computer, and that once consultation is done, that prescription going again with 3 mode: WhatsApp, email, and mobile app to the patient, investigation as, so that we are saving time. We are pushing information to the respective desk. So once patient reach there, then everything is ready. Means patient no need to spend much time. So that way, and this AI we used in the EMR, that technology, because if doctor is prescribing same thing, then it will come automatic, means as a suggestion. This patient last time came and you prescribed those things, so you want to utilize those, so doctor can take and it will go to their prescription. So that holistic OPD journey we started for the patient in 2021. So that way we manage that show to non-contact or non-touch transactions, either it's a financial or paper or material exchange, whatever.
Great. So when you are talking about this leveraging this AI on the EMR software, how does it connect or map with the HIS, the Hospital Information System? Because that will also include data from different processes in the hospital. So how does that integration happen?
Yeah, it's a API based integration, and our this HIS very much capable to provide the data or to receive the data through API, and whatever information pertaining to the in our case, best thing is before COVID only we made the one single bucket for holistic data. So everything within HIS, so that this AI pulling the data and pushing data to HIS to help the EMR prescription.
Okay, okay. And how about the during the COVID times? Obviously, that gained in prominence, the telehealth or the telemedicine part, the teleconsultation. How does your hospital support that, and what is the situation currently?
Correct. Uh, in healthcare environment, actually, patient always wants personal touch. We can say even during the COVID as well. Few patient mention a doctor spent time, but even he not touched a single time to assess our problem. Correct. So those things are there. So technology can help in the clinical care, but can't replace the this completely this personal touch of the doctor towards the patient. It's a like parent and mother, parent and child thing. So that is there. But during the COVID, yes, this was the afraiding thing, the touch factor, and then even we are keeping that 2 meter distance or 6 feet distance, all those things parameter. So telemedicine or video consultation, both the thing help a lot during the COVID. Whichever hospital were already there on the these functionality, they were handled patient very well. Which are not there, because solution were available on the market, so within a month or two they plugged in and they also came on board. So that telemedicine and tele video consultation both helped a lot during the COVID time, and even I can tell the ratio almost 25 to 30% patient were taking the video consultation from home. They were not coming to hospital.
Okay, and how, as a CIO, is the challenge now hospital, even the processes that you explained earlier, that will involve so many stakeholders in the overall hospital ecosystem. There is the doctors, then there are the caregivers, the nurses, and the other attendants. Then there is a whole lot of administration people, the payment, billing, accounting, the other operations people. Now, when the IT is being used to sort of integrate or connect all these stakeholders, and not all of them might be IT savvy also in that way. So, what are the challenges in sort of successfully integrating all these stakeholders in this technology deployment cycle?
Yes, you rightly pointed out here this adherence or adoption of the technology a bit reluctant. But during COVID or after COVID, that COVID changed mindset for each and everyone. Now IT is the thing where we can serve the patient, or we can reach to our target soon. So that way. Now coming back to the healthcare environment. So healthcare environment, yes, paramedical nurses, doctors, and this administrative staff, all those people are there. I'll give one example. Like doctor said, I am not comfortable to type the prescription. Then we given this voice or text over speech. Correct. If they are speaking, that text will type in their that particular segment. Then few doctors said, no, no, I'm not comfortable. I'm very good with the pen and paper. Then third thing, we brought interactive writing pad. Means we are giving pen and paper to them, but that information getting pushed. If it is some boxes are there, if they are tick on that box, that object value will go to the HIS. If they are writing something, because that can't convert 100% accurate, so we are keeping that particular paper as a PDF for future reference for like pharmacist, and even for patient also we are sending those. But wherever those objective values are there, that are getting pushed to the HIS, and HIS sending to respective places. So that way, so some 97 or 96% accuracy is there, but original paper also we are keeping in the system as a PDF, and sending same PDF to the patient, and e-prescribed EMR as well. So one example, like technology, we taken the feedback from doctor. First enable typing, second time voice, third time interactive writing pad. Similarly, in one time, in one go, we target one segment or one process. Then only we can achieve it. Otherwise, if we try holistic way, it is not possible, because if you bringing in the process, person A, person B will come out, will go out that way. So one process, one time, and finish. Also, we are with the help of managers. Management is very helpful, and then sometimes they also coming to ask what happened for this process. It is done or still pending. If our help is required, tell us. So that way, and that process owner only we are putting as a KRA to them. Means we can enable, we can help you, and wherever changes are required, we'll do, no reluctance. But you are the process owner, you have to get it done. So it is linked to their KRA. So that way we are managing and enabling the services one by one.
Great. So you have sort of institutionalized the even the adoption process among the stakeholders, so that there is accountability from their sides also. So the other
Yes.
challenge is, when as a CIO now you work with multiple IT vendors, the solution providers. I was checking you would be working with, I think, Wipro, Nutanix, and all the likes. So now uh, the challenges, and uh, obviously they will have those SLAs and conformance, but this is a healthcare sector, so there cannot be any compromise in terms of so how do you sort of manage those not just the SLAs but overall these relations with the solution providers, in terms of that there is no disruption in technology?
Correct. Being a healthcare, minimum side three solution or application is required to run a hospital. One is HIS, Hospital Information System, where entire clinical journey of the patient as well as their administrative journey capture. Second is PACS. PACS is a imaging solution. So every hospital having that PACS. Third thing, ERP, financial control like vendor payment, vendor management, and these billing data going to that ERP. So three this things is required to run a hospital. And fourth one is a communication, like any email channel or something is required to run a hospital. But now, like in our hospital, somewhere 20 plus application is running. Three basic things are there. On top of I need a feedback, then we plug in one of the vendor, or I need a QMS for this particular segment, we have to plug in one more vendor that way. Or this being a Japanese heritage approval process, so that software is required. They don't want to go on paper and approval. Means you have to initiate your request, it will go to next level according to the flow diagram, and then finally MD, and then sometimes goes to Japan also for the approval. So it's happening within a solution. All those things we have to some we made in-house, HIS Wipro. So two level of relationship we keep. One is management level, that is always necessary to run your smooth, to look the long growth or long run. Second is technology level, this syncing or relationship. So technology level, my team, Wipro team, or Nutanix team, all are there. But on management level, like in Nutanix, I can say Faz is there. So we very much associated with it. When something goes wrong beyond this technical team, we can talk to them. Same way in Wipro. So Wipro also technical team talks to each other, but on management level also they usually talk once in a month, or once in 2 months, and then they exchange the ideas and all. That way we are managing our show, and the solutions. uh, and one more thing, when you are selecting any partner, you have to see the sustainability as well, because in healthcare industry no hospital going to shut down. They run for 50 year, for 70 year, even, which I can see from the past to now, future. So the partner which you are engaging, that should sustain, means it should not close their shop for next 3 4 year or 5 year. So that angle also need to bring into the technology when you are selecting for your organization.
Okay, in terms of the this relationship, and when you are saying you plug in each of those solution providers in terms of the overall process. Now, my question is, there are multiple areas, and where you have to have some criteria for a particular selection, certain parameters by which you would. So, how is the choice determined? Is it from the management from Japan only, or is it more at the local level? And what are those parameters or criteria on which those selections are made?
Solution or technology selection is on India level only, and we have our group CEO and MD and DMD who sits in India. So they take the decision. But yes, certainly time where we have to send the information solution along with the cost to the Japan, so they approved. And budget concept is very much familiar in this organization. So once it is approved in budget, then they only come and ask why it is not happened. So those things are there, but the decision on technology level, solution level happening in India. And as you asked for the selection criteria, yes, for each solution, as a process, we take the solution detail from the three partner. So compare those based on the features, required features, and required feature we take from the end user. Means few standard features are there. where solution provider can provide you, or you have your own knowledge, you can create it. So we called RFP. So we developed first RFP with the help of our knowledge, management input, some vendor input, and end user who's going to use that solution or that application. That way, once RFP is done, RFP we segregate in two segments. One is basic need, one is wish list. So wish list we keep for second phase. So a basic need we align with the vendor, and then finalize this T1 like technology one, and commercial L1 L2, like that. So once those match, and we'll see the sustainability of that organization, how long it can sustain. So those idea, yes, even we don't know the future of any organization or even any individual, but still some predictions are there. On based on those parameter, we decide the right partner, and then go with those partner for the implementation and taking the solution in place.
Okay, so now if we look at currently, or maybe over the next few quarters, in terms of the most important critical technology deployments, what are there on the anvil, and what are the objectives of those deployments going to be?
Okay. Huh. Okay. Like 2 years ago, we started this OPD patient automation, that journey automation. Same way, we are in the way to bring the IPD patient automated journey. Means everything is going to happen within a patient bedside. Nurse or doctor will not come out from the patient room to nursing station and feeding the information into the HIS. So what we planned, it is in this development phase. So what we planned, we'll deploy one touches screen in each room. And there are four major segments: doctor care, nursing care, and clinical nutrition care. And then all these three things will be authentication based. Means no one can open. Whichever we allow, they can go stand in front of that screen will open that application, and they can do the feeding, and some few seconds are there. If they are out from the screen, it will get auto lock. And three open things like nurse call, service request, AC not working, TV not working, or need a food or water bottle for patient purpose, so they can request. That is open thing. And third is orientation video. Means patient can see anytime, like where is cafeteria, or where is IPD billing, so they can navigate, or they can see some important surgery video, or something, or Sakra is giving some promotional things or discount, so we can show there. So that is, so three is controlled access, three are non-controlled access. So those things, whenever doctor goes in round and saying like this patient do the CBC, so no need to come out, no need to write any pen and paper. Then and there, either doctor, treating doctor, or they always go along with their junior doctor. So junior doctor can feed on behalf of that doctor same time. So no error, no chance of clinical error, and time also consuming less. Nurse can focus more on the clinical care instead of this clerical job, like noting down from there, coming to desk and feeding into HIS, then taking follow up from the respective department. It is came, medicine came, or patient they take away for x-ray or not. So all those things, if like they define the x-ray in 12 o'clock, and 30 minutes is a buffer time. If nobody responded in 30 minutes, then that will escalate to nursing supervisor. The nursing supervisor also not acted, then it will go to the medical director. So that way, those notification and hierarchy we brought, that smartness into the system, so that it should be a system control, not the man control. So that
Okay,
IPD automation journey we are working. Maybe by this year we will make it go live.
one question: when you're talking about this automation journey, one critical factor would be the quality of connectivity. And we know there is still sometimes a lack of standardization in terms of the quality of connectivity. So how do you tackle that challenge?
Very true. One is your platform. So platform, like as you mentioned, Nutanix. So we believe on Nutanix and that SCI, and it's a flexible, some slowness is there. So you can increase the RAM, you can increase the this cores, and then you can get more performance. So one segment is there. So that segment we are perfect. Now coming back to connectivity. So being a healthcare, even most of the healthcare in India keep their data center on prem. They don't want to go on cloud, or some SaaS service they taken. Even we also taken one or two SaaS services, but our core application running on prem. So within a LAN, there is a very less chance of connectivity. Yes, that solution it is coming through the MPLS or through the P2P connectivity or SD-WAN, then there is a chance, because every third day that roads are digging, cable is cut, and then how you will manage. So and here technology belongs to life, means life threatening technology, not belong to the revenue. Correct. If you talk about bank, technology is not there, so some commercial loss will come. Here life loss will be there. So that way all healthcare wants their data center within a premises.
So the last thing I would like to understand in the overall healthcare ecosystem, when we are talking about technology deployment currently as of today, what are, according to you, some of the biggest challenges, and how would you advise to sort of meet those challenges?
One is still that adherence thing. This, because we being a technology leader, we can enable the technology, and technology can do these days almost all the things which you want, generative AI and many other things about to come, RPA, bots, ML, IoT, even healthcare. IoT is the biggest segment where we are focusing and we are enabling. Means we can treat the patient from home. We are putting all those bedside monitor, ECG, this vitals, all those things with the patient, because patient can't afford the hospitalization. So at home on nominal cost, they can take the treatment at home, and those information will come real time to the hospital, and treating doctor can see in one go what are the parameters, anything need to change and or not. So that thing is there. One more sector is there where the solutions partners bringing the solution in silos, means they have developed the solution, but it is not closely in line with the process there. So most of the startup getting failed because of that, because they made the solution smart and very agile, but it is not in line with the process 100%. So that before developing any solution and something, they should speak to this expert, subject matter expert guy. If they are developing solution for healthcare, they should speak to the particular process owner and all. And one more challenge is there in IT segment, which we feel that a consolidation of IT services. Each hospital having a like 10 plus or 20 plus or 15 plus application, which is very difficult to manage. So some vendors should, or bigger vendors should focus on those. Means one is giving only QMS, one is giving appointment solution, one is giving feedback. So if one vendor only can give all those, then this manageability and then bringing solution, or cost also, because whatever cost incurring, that will get passed on to the patient. So if one vendor only giving all those, less cost will go to the patient, and economical clinical care will happen. So our thought process to bring down, use the technology and bring down the cost of clinical care. If it is getting increased, then there is no meaning, because pen and paper also we were doing.
Exactly. So, manageability, the cost factor, the budgetary factor, those obviously are the critical issues, and where the technology is required to sort of. But again, in your experience, when you are working with multiple vendors or solution providers, in today's age, when there is specialization, trying to have lesser vendors or getting more and more areas from the same vendor, isn't that a little bit problematic, or is it better in that way? What do you feel?
No, it will not more problematic because yes, vendor selection is a superior thing where you have to select the right vendor on right time. But if you take the solution from A, B, C, D vendor, then all vendor have the same that solution is not going to work. So the technical manageability also is the biggest challenge in multiple vendors. One is okay, like vendor A, we taken A, B, C, D solutions, but now vendor A is going, then what will happen? You are right, but that is a very less chance. Biggest chance are there where you have multiple things plug in with the single system. So where is gone wrong, you cannot identify, and it will take more time, and you are engaged more with the vendors instead of focusing on the business processes.
Exactly, exactly. Okay, thanks a lot for your time. That was very beneficial for our viewers. And if there are certain more clarifications, I'll get in touch with you over mail. And thanks for your time again.
Thank you, Mr. Rajneesh, and thank you everyone who patiently listen. Both of us. Thank you so much.
Thank you. Thank you.